So I don't know if the people on Zoom can hear me or not.
Yes.
Awesome. Thank you so much, Dominic. So good morning, everybody, and welcome to my grand rounds that's titled Thrombolytics in the Extended Window Stroke. So I don't have any financial disclosures. The learning objectives today will be to kind of like be able to understand and kind of like explain the concept of ischemic penumbra and the patients who are candidates for thrombolytics in the extended window, and compare that with the efficacy and safety of intraarterial and intravenous thrombolytics, as well as be able to kind of like interpret some of the imaging modalities that are used to do this the screening. I have the CME code there, as Lydia requested. So as we know, about 50 million people every year annually experience some type of stroke, and about 5 million of those die, and 5 million end up with permanent disability. The treatment of ischemic stroke has evolved over several decades from just antiplatelet to thrombolytics to mechanical thrombectomy, and it's a field that's continued to evolving. Unfortunately, even despite mechanical thrombectomy, only 30% of patients will have functional independence, and the rest of them will have 54% of those patients with severe stroke will have some functional dependence or die. And the ones that survive, about 72% of patients end up with some kind of disability. And the reason for that being is that I just wanted to talk about it briefly here, is that there are kind of like micro circulation, and there's two hypotheses. The one is that when the stroke happens, there's already kind of like irreversible injury to the area that is what we call penumbra. And the second hypothesis is that there is impaired reperfusion of the microcirculation. Some data suggest that there is, and the microcirculation is perfused by capillaries. And some data suggest that every neuron in our body has a capillary, so up to like 90% of that is perfused by capillaries. I kind of like wanted to go briefly about the coagulation cascade. As we know, we have the intrinsic and the extrinsic pathway that combines into the common pathway, and you have factor 10A that, with the help of factor 8A, 7A, converts into 10A, and then 10A helps with 5A to convert prothrombin to thrombin, and then thrombin is the activator of fibrinogen to fibrin that ultimately forms the fibrin mesh or clot, and that clot is kind of like broken down by plasmin, and plasmin is converted or kind of like enhanced conversion of plasminogen to plasmin by thrombolytics. And we know that you can use antidotes like aminocaprylic acid to reverse that sometimes. So penumbra, basically, scientists have been looking at this for a very long time, but it wasn't until 1981 when Dr. Astrup and Simon kind of like defined it as an area of reduced cerebral blood flow with absent spontaneous or induced electrical potential that still kind of like maintains its ionic homeostasis and transmembrane electrical potential. So the cerebral blood flow in this penumbral area is gradually increased as you move away from the core, meaning that if the core, as you go further away from the core, there's a more area of brain that is at risk of getting infarcted. And that is kind of like the theory behind it, that if you reperfuse the area that is still salvageable, that you can kind of like save that portion of the brain. And failure of electrical activity was not uniform across the ischemic area. And some tissues, regardless, despite of like having a severe ischemia, was still viable. And that is kind of like where your cerebral blood flow blood flow comes in. In this picture, you can see that the cerebral blood flow, as it goes low, so above 35, 38 is like normal blood flow. If you go below that, between 20 and 35, 38 is an area called oligemia. And then if you go below 20, then you start getting ischemia. Dr. Simon and Astrup kind of like defined it as a kind of, if you go below 20, you get electrical dysfunction. If you go below 15, you have like complete failure. And then if you go below 5 ml per 100 gram per minute, that's where you have release of potassium and cell death. And you can see here, as the time expands, the area of ischemia or infarction grows exponentially. This is another diagram that illustrates that. I wanted to kind of like discuss about some of the imaging modality to diagnose the area of at risk versus brain tissue that's already infarcted. The first imaging that were used were the PET scan and the SPECT scan. That's less used these days because of the availability and more cost effectiveness. So we use mainly CT and MRI. On MRI, we look at the DWI ADC to determine what the ischemic area is. And there is a sequence called perfusion-weighted imaging, PWI. And if there is a Tmax of more than 6 seconds or delayed time of more than 3 seconds, we look at the mismatch between the DWI and the PWI, and that gives you the penumbral area. On the CT scan, it's similar. If you have cerebral blood flow of less than 30%, and on the Tmax more than 6% or DT of more than 3 seconds, Tmax of more than 6 seconds and DT of more than 3 seconds, that defines your penumbral area or the mismatch of that. At our center, we commonly use CTP because of the availability, the time, and low cost. This is a PWI DWI mismatch. The blue is the ischemic core, and then the red is the penumbral area. This is a CTP. The red is the, let's do this. The red is the core, and the green is the salvageable tissue. Okay. So the oligemic zone and is a dynamic feature of ischemic penumbra and core. So there are some mechanism, and I won't be able to talk about like the underlying mechanism about that, but basically what it says is that within the oligemic zone, that can last for like many hours to weeks to months, sometimes even years. And if you have like a reperfusion, even delayed reperfusion, you can reestablish function of those neuronal cells and kind of like vascular cells within the ischemic core itself. So there has been a lot of research ongoing. We've come a long way. The initial, ischemic penumbra was described in 1977. In 1981, it was kind of like defined. We started the FDA-approved TPA for myocardial infarction in 1987, and then it wasn't approved for ischemic stroke until 1996 after the NINS and ECAS trial. And the FDA approved it for up to 3 hours. Now, after the ECAS 3 trial and the EPITET trial in 2008, the American Heart Association basically came in with an advisory that we can extend the window to 4.5 hours. However, this never received FDA approval. So it's kind of like an off-label use. And then after the Diffuse 3 and Dawn trial, which was kind of like for mechanical thrombectomy, we expanded the window for intervention up to 24 hours. Okay, so regardless of the treatments that we have available, we know that the majority of the patients, up to 75% of patients, usually come in after 4.5 hours. Now, the question is, should these patients get thrombolytic therapy or not? What do you guys think? Let's say up to 24 hours. Dr. Brown says probably not. So to answer that question, there has been a lot of research going on, and I want to focus on that today. So I'm going to be highlighting some clinical trials that have been done. There's obviously dozens of trials that has been done and ongoing, but I won't be able to talk about all of them. But I wanted to highlight some of them today. One of the study that was done in China that came out last year called the EXIT-BT. It was a multi-center phase 2 open label blind endpoint RCT that kind of like looked at tenecteplase plus NBP versus placebo. NBP is a kind of like derivative of celery oil. There is research independently about NBP. It says that there's 3 ways that it benefits in ischemic stroke. One of them is that it works by protecting the blood-brain barrier, preventing fluid and harmful substance to kind of like enter the brain. It enhances the cerebral blood flow, and then essentially delivering oxygen and nutrients. And lastly, it also inhibits platelet functions and decreasing the clot formation. So the collaborators of EXIT-BT wanted to look if there is a benefit of combining TNK with NBP and for stroke patients. So they included close to 100 patients. On average age was 63. Baseline MRS was 0 to 1, NIH of 5. And they included these patients based on non-con CT and MRI. And these patients were 4.5 hours to 6 hours. And they didn't care about where the occlusion was. And these patients did not get mechanical thrombectomy. The average time from last known normal was about 5 hours. So what they found is that patients who received TNK and NBP had a significant decrease in their NIH score at 24 hours, and they also had a significant improvement of their functional status at 90-day. As we see on the MRS score here, that was noted. The secondary outcome was to look if it is safe in these patients or not. And the way they did that is to look at the ICH or any type of ICH and symptomatic ICH. So the symptomatic ICH score was non-significantly kind of like the same in both groups. One other study that was done is called the Wake Up study. So a lot of us know about this trial. It is a multi-center European trial, phase 3, double-blinded, placebo control. They included about 500 patients. On average, the age was 65. It was an unwitnessed stroke. The reason for that being is that patient went to sleep at night, didn't know what time they went to sleep, or went to sleep at daytime, or they were aphasic, confused, and couldn't tell what the last known normal was. They included these patients based on MRI DWI flare mismatch, and they used alteplase versus placebo. Majority of these patients were anterior circulation. There were a few that were also posterior circulation, and the average time from last known well was about 10 hours. So what they found is that patients who received alteplase had a significant improvement functional status at 90 days with the MRS of 0 to 1, 0 to 2. And the mortality and the SICH rate was non-significant, kind of like similar to both groups. And here you see that. Another trial that was done, also very famous, is the Timeless study. This is a study that was done in US and Canada, and it was done from 2019 to 2022. They compared tenecteplase at a dose of 0.25 mg per kg versus placebo. The average time of onset was last known normal was 12 hours. The baseline MRS was 0 to 2. NH, median NH was about 12. So moderate to severe stroke patients. These patients were included based on CTP or MRP. And they made the inclusion criteria was basically ischemic core of less than 70 ml with a mismatch ratio of 1.8 and a penumbra of more than 15 ml. They looked at the anterior circulation stroke. Another thing in this trial was that majority of the patients did receive mechanical thrombectomy. So what did they find? They found that there is no significant difference between receiving tenecteplase versus placebo. There was no difference in functional status outcome at 90 days, and neither was there a significant difference between the mortality or the SICH rate. There was slightly higher bleeding in the alteplase group. This kind of like shows that patients who get mechanical thrombectomy has a small core and, you know, the anteriors, the M1, maybe M2 location site has some more benefit from getting tenecteplase. Then in 2023, another trial came out. It's called the ROSE TNK. It's a multi-center Chinese study, phase 2 blind-ended RCT that looked at tenecteplase versus control group. In the control group, patients received, it was initially unclear, but when I looked again at it, patients received basically antiplatelet, IV fluids, and the routine stuff that we do on the stroke service for patients who don't get thrombolytics. So what they found, so these patients were included based on like awakening, or they did not know exactly when the last known normal was. The baseline MRS was 0 to 1, and these were patients with moderate to severe stroke. The ischemic core in this study or this trial was pretty small. It was like on average 0.32. And they looked at both anterior and posterior circulation. These patients did not get mechanical thrombectomy. This is kind of like they screened 166 patients in their center, like the multiple centers, and they were only able to randomize 80 patients, 1-to-1 randomization. And what they found is that there is no significant difference between the TNK group and the control group for functional outcome at 90 days, paired with the MRS of 0 to 1 or 0 to 2. There was also no significant difference between the mortality and the SICH rate. There is slightly higher adverse events and severe adverse events, and adverse events included like dyslipidemia, MI, DVT, pneumonia, diabetes, appendicitis, those kind of things. And then severe adverse events were, carotid stenosis, SICH, and malignant strokes. Then came the TRACE-3 trial, which is also a Chinese trial. This came mid last year, or was published mid last year. It's a phase 3 open label blind-ended RCT that again looked at tenecteplase versus placebo. They included about 500 patients, were included based on perfusion imaging. Baseline MRS of 0 to 1 with a moderate to severe stroke. They included mainly anterior circulation patient. The last known well from to intervention or randomization was about 12 hours. So what they find in this study, so they found that there is a significant difference in patients who did get tenecteplase with a p-value of 0.003 and the symptomatic symptomatic ICH or mortality was non-significant between these two groups. So there is benefit if you do tenecteplase. At least that's what they found in this trial. Another thing to mention is that the patient in this trial did not get mechanical thrombectomy. And compared to the timeless trial, those patients, majority of those did get mechanical thrombectomy. So I just want you guys to just keep that in mind. Now, there has been so many trials ongoing. And instead of talking about each individual trials, I wanted to basically look at a systematic review and meta-analysis. And Dr. Gunkan, who has done, with his team, has done this systematic review and meta-analysis. He included some of these trials that I've talked previously, but a few more. I think 4 of the trials. And then there are a few other trials called the Epithet, the Extend, the ECAS4 trials. We couldn't get the full paper for the ECAS4 trials. The Rostian, the TOS trial, and the Extend trial. So those were, I haven't talked about that, but those were also included in this meta-analysis. So basically people who were beyond 4.5 hours and did not get mechanical thrombectomy. So they included a total of 1,750 patients, average age of 70. And what they found is that IV thrombolytics had a higher rate of excellent functional recovery at 90 days. However, they also had like a higher rate of SICH, and the mortality was not different between either group. When they did a subgroup analysis, they found that if you screen and include these patients based on perfusion imaging, there's a higher kind of like recovery for these patients. And the other thing that they found is that the patients who received tenecteplase did better than the patients who received alteplase. And here we can see that there is a significant benefit of doing thrombolytics within the extended window. And there's no significant SICH or mortality in these people, in this group of patients. The previous trials that I've discussed, some of them included posterior circulation, but I wanted to highlight this recently published trial that came out earlier this month, alteplase for PCA or posterior circulation stroke at extended window 4.5 to 24 hours. It was a randomized controlled multi-center trial in China. They included about 234 patients. They randomized 1-to-1 intervention and placebo. They included patients who had mild strokes with no extensive hypodensity on the CT scan. And what they found is that patients who received alteplase had a significant better outcome, functional outcome at 90 days, and the SICH and mortality rate, which are the safety outcomes, were not significant between these two groups. So they conclude that it is safe. Alteplase can safely be considered with up to 24 hours post for posterior circulation strokes, and especially if patients do not get the mechanical thrombectomy. So I have to turn on the CME codes. Now, I wanted to kind of like talk about the intra-arterial thrombolytics as well. We've talked about IV thrombolytics, but is there a place for intra-arterial thrombolytics in stroke? What do you guys think?
I would say there is. They just have to figure out who the right patients are. IDs before recanalization, to be depending on how much reperfusion you get. There are some patients that you can't even get to the clots. So.
Right, yes.
And especially when you're patients who have improved outcomes.
That's right, yeah. So like Dr. Fakri explained, you have to look at the patient population, individualize, and decide on like if it would benefit or not. So there has been a few trials that has been conducted. Some of the landmark trials the PROACT trial. This is the PROACT 1, basically a phase 2 trial that looked at recombinant UK, pro-UK, which, you know, they directly injected into the MCA stroke. That was followed up by this study was basically terminated early. They didn't include many patients. The PROACT 2 study was done the following year. And then there came a Japanese trial called the MELT, and they also looked at the MCA strokes. All of these patients, or all these 3 trials, kind of like included patients up to 6 hours post-stroke, post-onset. In the PROACT 1, they only had like 40 patients with MCA strokes. They included up to 6 hours, and they did intraarterial pro-UK plus heparin versus heparin only. And they found that 66% of patients who got the pro-UK had a higher recanalization rate versus patients who did not. And they had a similar finding in PROACT 2. In MELT, they didn't report the recanalization rate, but they did mention that the functional independence was not statistically different between the 2 groups. In the PROACT 2 trial, they did find that the functional independence at 90 days was significantly better in the group that received the intraarterial thrombolytic. So 2 decades forward, those studies were done in 1998, 1999. 2 decades forward now, there are still trials ongoing to further look into this. And one of them is called the CHOICE trial. This was conducted in Catalonia in Spain. And they basically included, they screened 1,825 patients, but only 121 patients were included in this trial. And they were kind of like close to 1-to-1 randomization. This is the basic characteristic of the patients that were included. And you can see that the baseline NIH was about 14, so moderate to severe stroke patients. And the last normal to randomization was about 5 hours, 5 to 6 hours. Majority of the patients were included were anterior circulation stroke. So what they did is that these patients came in. Some of these patients did receive alteplase prior to mechanical thrombectomy. They went to the angio suite, they got mechanical thrombectomy, and they looked at the recanalization rate. And majority of them had a TK2B or TK2C up to 3 reperfusion rate. Now, as I had mentioned earlier, that there is impaired reperfusion of the microcirculation. The thought behind doing this study is that recanalization does not always mean that they will have fully functional independence. And the researchers in this trial and many other similar trials thought that if you give them more thrombolytic after the mechanical thrombectomy, if they have incomplete recanalization or reperfusion, is there going to be a benefit from that? So these patients were included. What they did, they gave like intraarterial alteplase for a dose of 0.225 mg per kg. With the maximum dose of 22.5, that was infused 15 to 30 minutes after the procedure. Now, what did they find? So they found that the patients who received alteplase, intraarterial alteplase post-mechanical thrombectomy, did have a significant better functional outcome at 90 days. There was no significant difference between the SICH or mortality, as you can see here. And this is the kind of like the scale at 90 days. Then they did another study that came out earlier this year, or was published earlier this year, called the post-TNK trial. And the goal was to kind of like see if adjunct intraarterial thrombolytics, in LVO patients who received the mechanical thrombectomy with the TK2B, 2C reperfusion, if they would benefit more from it in terms of functional independence. So these patients, like in contrast to the choice trial, did not get any thrombolytics prior to the mechanical thrombectomy. And they gave the patients intra-arterial tenecteplase compared to like alteplase in the previous study. And this is the baseline characteristic. They had like moderate to severe strokes, and average time to randomization was about 8 hours. And majority of them were like anterior circulation. And post-mechanical thrombectomy, they had a TK2C or TK3 recanalization. So what did they find? So they found that there is no significant difference between doing intra-arterial TNK versus control group. There was no difference between functional status outcome at 90 days. And there was also no significant difference between the mortality and the SICH. However, they did show that, there is no, basically the goal was to show that if there is any increased risk from doing intra-arterial TNK. Now, lastly, about the intra-arterial thrombolytics, I wanted to talk about the ALI pilot trial. This was a single center trial that was done at ProMedica Hospital in Toledo, Ohio. This is a large center. They did like within a year, they did more than 200 mechanical thrombectomy cases. And so there has been similar trials conducted prior to this. But on this one, they wanted to see if adjunct intra-arterial TNK increases your risk of hemorrhage or if it benefits patients in their functional status outcome. And these are the kind of like inclusion criteria. And what they did is that the patients, some of these patients had received thrombolytics prior to their mechanical thrombectomy. And post-mechanical thrombectomy, patients who had like incomplete reperfusion with defined by TK2B or 2C score. If that was the case, they had a 10-15 minutes window to consent the patient or the family member. And these patients, they got intra-arterial TNK boluses. They got 1.5 milligram within 1 minute, and then there was a 5-minute wait, and then they reassessed to see what the reperfusion rate is. If they had less than TK3, then they would get another bolus in a similar fashion. And if the reperfusion was less than TK3, they would do a third bolus, and that would be the final bolus. And what they found is that about 55% of patients post mechanical thrombectomy, post intra-arterial TNK had a final recanalization rate of TK2B. 35% had a score of TK2C, and about 10% of patients had a final recanalization rate of TK3. Any ICH was about 11% in this group, and there was only one patient that had a symptomatic ICH. They achieved their end goal of MRS of 0 to 2, like functional independence, in about 50% of these patients. So they conclude that the use of intra-arterial TNK up to 4.5, they basically wanted to assess the dose of the TNK and for safety, that up to 4.5 in acute ischemic stroke with incomplete reperfusion was feasible. You can do it without the increased risk of hemorrhage. Now, I wanted to kind of like briefly talk about the CRAO because this is a condition that is disabling, same like aphasia. And we do get a lot of patients with the CRAO or BRAO. And unfortunately, only 6% of patients with CRAO come in within a 4.5-hour window to be able to receive TNK or TPA. And only 50% of those patients will show clinical improvement, with the acuity of 20/100 instead of 20/200 if they don't receive anything. There has been many European trials done, like the DEI, AI, and the revision trial. But one famous trial called the Eagle trial kind of like included patients up to 24 hours. And these patients were treated with intra-arterial thrombolytics. The study was unfortunately terminated early due to clinical equipoise. However, these patients were treated with actually timolol. They were treated with IV Diamox. They were treated with hemodilution, and some of them were also treated with hyperbaric oxygenation. So, the researchers were kind of like unsure if the benefit is from intra-arterial thrombolytics or from the other treatment that they received. However, the American Heart Association came with the scientific statement that there is data that suggests that IV thrombolytics is helpful and may be effective, but you have to screen these patients and treat their vascular risk factors. Just wanted to kind of like talk about the vascular anatomy. You have the ICH, and then the first branch is the ophthalmic artery, and then you get the central retinal artery, and then you have the branch arteries. Unfortunately, the ophthalmic artery is, the diameter is 1.3 millimeter, and the central retinal artery diameter is 160 micrometer. So, with the current devices that we have, I don't think it's feasible to reach all the way that far, unfortunately. Now, intra-arterial thrombolytics has a benefit because you can directly give them the thrombolytic and without the, increased risk of intracranial or systemic hemorrhage. But you have to look, and the dose that we give is not high enough to cause those side effects as well. Unfortunately, you have to weigh the other side of it is that you can, cause iatrogenic arterial dissection, spasms, dislodgement of any plaque that's sitting there. So you have to look at all of those things as well. This is kind of like fundoscopic imaging and OCT imaging. I'll just skip over that, and then the American Heart Association has this diagram published on in their article. Basically, they say that whenever a patient comes in with acute monocular vision loss, painless vision loss, you screen them, and we are fortunate that majority of our UofL ED, the residents are pretty good in doing ocular ultrasounds. And, the main thing that you want to rule out is there retinal detachment? Is there any intraocular hemorrhage? Or if there's like concern for optic neuropathy? If that's the case, then you have to treat it appropriately, like with those things. And if there is a CRAO concern, then you do the second step, you get like CT brain, and you get basic labs to check. If you think that this is arthritic, then you treat it with like steroids. But if you think that this is non-arthritic CRAO, then you divide two groups. You have, if the patient is within 4.5 hours, and there's no contraindication, you do IV thrombolytics. If they are beyond 4.5 hours, then you usually transfer them to a center that is capable for doing intra-arterial thrombolytics. The American Heart Association actually says that up to 6 hours. However, in the Eagle trial, they included patients up to 24 hours. Now, our institution has came out with a policy, I think last month, that we will consider patients up to 12 hours for potential intervention. And, whenever a patient comes in, you screen them. The opto resident or attending needs to evaluate the patient. The stroke resident needs to evaluate the patient. And, based on individual cases, they may consider taking these patients to the angio suite to consider intra-arterial thrombolytics. Now, in summary, from all of these studies, or some of these studies that we have seen, there is, some benefit of intra-arterial or intravenous thrombolytics in the extended window, causing, delayed reperfusion. both in patients who received mechanical thrombectomy and who did not get mechanical thrombectomy. And that can translate into a higher functional outcome with comparable kind of like safety effects. We understand as well that, better recanalization does not always mean a better functional outcome. And we have seen that the patients who were selected based on the perfusion imaging had a better functional outcome than patients that were not selected based on those scans. So there are a bunch of clinical trials ongoing. There's a Choice 2 trial going. There's a Techno trial going. There's a Tempo 2 trial going. There was another trial, Eternal LVO, that was actually kind of like last month they announced that they terminated that study early, but there are so many other trials, the Pearl trial, the Post-UK trial that are still ongoing. And basically the goal is to find the right patient population based on this advanced imaging and see which patient would benefit the most in getting like thrombolytics in the extended window, whether that's IV or intraarterial. And obviously more study is needed to get more data. Majority of these studies were done in a small patient population, 40 or 80 patients, and some of them did include like up to 500 patients, but still that's still not enough patients. And I wanted to kind of like conclude my presentation with a video here. Hopefully it's going to open.
Hey, boss, I got a question. Yeah, go ahead. Just watch the YouTube video first. No, I was wondering if you've ever used tenecteplase to treat an ischemic stroke.
I don't know if that's by yeah, do you know how I can this is going to show up. There you go.
Hey, boss, I got a question. Yeah, go ahead. Just watch the YouTube video first. No, I was wondering if you've ever used tenecteplase to treat an ischemic stroke. Oh, no. Don't say that. Why? What's wrong? Did I just hear a thought-provoking question from the emergency department? What's got me in your neurotransmitters? I was having such a good shift. It was me. I was reading about a thrombolytic agent, tenecteplase. Oh, it's quite effective if used within 4.5 hours of a large vessel ischemic stroke. Endovascular thrombectomy is better. Yes, that would be best. Imagine what you could accomplish by mechanically unblocking large swaths of your cerebral cortex. Yeah, okay. Unfortunately, not everybody has access to thrombectomy, and many patients fall outside the 4.5 hour time frame for thrombolytics. What about that paper published in the New England Journal of Medicine? Continue. You don't know. I know about it, just remind me. Hang on, just want to bask in this moment for a second. Over 500 Chinese adults who had salvageable brain tissue between 4.5 to 24 hours after an ischemic stroke, but without access to thrombectomy, were randomized to receive IV tenecteplase or standard antiplatelet therapy. What did they find? Tenecteplase resulted in a higher percentage of patients with no disability at 90 days compared to standard treatment. That's very impressive. Thank you. I didn't know you could read.
So yeah, that he was talking about the Trace 3 trial that was done in China. Unfortunately, those patients were in the rural area and they didn't have access to centers who could perform mechanical thrombectomy. Yes, and so yeah, that's my presentation, and again, questions that you guys have. These are my. Thank you.
So we use or
I
don't use connected?
So, if you ask my personal opinion, I think based on the data that I have seen so far, I think it depends on the patient itself. In the TRACE-3 trial, we have seen that even patient with the large ischemic core up to 100 cc were taken or have been given thrombolytics, and those patients technically did great. So I think it depends on the patient situation, but we should consider it. Yes. Dr. Nasir, yeah.
Yeah, a great representation on
Thank you.
100 trials.
There has been hundreds of trials. Yes, I could not get. Yeah.
Great job. I guess the main thing I was gonna ask is the trials you saw, it was a recent one from Journal of Medicine.
Yeah.
Did you see anything else in terms of did they all adjust to the anterior circulation? Remember, we have a lot of vertical lesions and
Right.
P1 and other surgery.
Right.
Sometimes right outside the window, it's a little bit of a different factor in the posterior circulation in terms of vitamin C and treatments on kilometers. So I don't know, you heard of anything else besides the most recent one that came out?
So that was the question is if there is like more trials ongoing in the posterior circulation trial. So the one that I kind of like showed, that's the most recent one that I know of. I know there have been, what they're trying to do is do like meta-analysis of case reports or case series that have been conducted, but like randomized control trials, I'm not sure if there's like more of those in the posterior circulation itself. But the previous trials, they did include patients who also had like posterior circulation strokes. Any other questions?
Hey, Ravi. Hey, can you hear me?
Yes, Dr. Hassan.
Yeah. Great presentation. I think, you asked a question in the beginning whether we should give thrombolytics in the extended window or not. So the answer right now is really simple. It really depends where you are practicing, one. And number two is, it is a case by case selection, and it needs to fit a certain set of criteria. So if you look at the European stroke guidelines, they actually recommend giving TNK or TPA beyond 4.5 hour window up to 9 hours in certain patients who fit the criteria. So what needs to be done is, if you have, especially in current era when now more trials are coming out where your distal vessel occlusions are not, too amenable for thrombectomy and they don't have a great outcome. I think those are the patients that carefully need to be selected, and where TNK should be offered beyond the 4.5 hour window. Also, very important thing to keep in mind is that it should be family's decision in the end. So you present the data to them, let them know that you're offering a better chance of recovery, but you're also offering or giving them a higher chance of a symptomatic intracranial hemorrhage, right? And then they need to decide whether they're okay with accepting that risk versus benefit discussion, because that needs to be well documented when we're doing it. But I agree. I think we this is probably the next thing that's going to come out in stroke, the extended window, and we have enough data to really support with what we're doing. Again, not for everyone. it should not be given for patients who don't have vessel occlusions, especially the ones that are going for thrombectomies. So what other centers are doing, that they have reserved this mostly for a primary stroke center where there are distal occlusions, and they do the the drip and ship. So they give these patients TNK beyond 4.5 hours and then bring them over for thrombectomies. So that is also one situation where you can consider it, but it really has to be a case by case selection.
I fully agree. Yes. It's a case by case selection of these patients, and depends. Obviously, you have to talk with the family, and present them the data, and let them make the decision. Yes, Dr. Brown.
So we know that there are a lot of tissues that tolerate ischemia much better than the brain. And actually, even in the brain, there's parts of the brain that tolerate ischemia
Right.
better than other parts. And
Sure.
so has anyone looked at the retinal tissue to see, is it more like,
Mhm.
cortical, die quickly, or is it more like, has anyone looked at how well does the retina tolerate this? Because that would change the window dramatically if you had tissue that could be salvaged.
Yeah, absolutely. I'm not sure if there has been any trials done on looking at which tissue is more viable or susceptible to deoxygenation or ischemia or not. But the American Heart Association, their statement, they're basically are mentioning that there are retinal cells that, as you're mentioning, are more susceptible to ischemia than others. But I had also discussed that the ischemic core and the area surrounding it, the salvageable area, is not uniform. So some cells are more prone to ischemia, some are not. And it's the same with the retinal cells. That's where the hyperbaric oxygenation treatment comes in, because they say that if you give them hyperbaric oxygenation, you can still salvage some of those cells even before giving thrombolytic treatment. Unfortunately, there's no clear data on which cells and how much you should do to salvage that. Yeah.
The time going in either the Eagle trial was from many years ago.
Right.
I remember the instruments we were using were different. Some of them were catheterizing the ophthalmic artery, we don't do cases. Usually an ostium the artery that inject the
Yeah.
PA, but I think for Dr. Brown's question also, our understanding of retinal tissue is extremely susceptible because there's just that one small artery from the central artery.
Yeah.
So no one, we don't have weird. It doesn't have
Right.
the same efficacy as other systems. We give up to 12 hours. To try to improve people in terms of. It's not clear if it's efficacious or if there's even what the harm is. How and balancing that is very hard because we don't know is the retinal tissue already ischemic in 4 hours.
Right.
And even if it is, let's say
Right.
your TPA. Is it going to be more prone to bleeding 10 hours out, or are you
Right.
just we don't actually know. But I don't know probably if you saw in your review what the timeline the Eagle study and what AHA was.
I didn't look in detail what the age, the demographics was of these patients, but they did include patients up to 24 hours. Yeah. And that other studies, the DIA, and there's another trial that was done in Europe as well. They included patients up to 4.5 hours for thrombolytics, patient with CRAO. Yeah.
Yeah, 1 hour is great. You can give
Right.
people,
Right.
Go out.
Yeah. 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 I heard that there is a hyperbaric chamber at Jewish Hospital, but I'm not sure if we've ever had to use it or if it's still functional. It still works. Okay.
Sign is still up on the door.
Yeah.
Circulation is the same, so mentioning hours, that curves from one chromosome to the other one. And that could be also the reason why Bobby was saying like in the same number, you might have areas that cells are a little bit more affected than. Maybe
Yeah.
those areas, have people in allowable circulation and not as much circulation as other areas, and that can be also a reason why we only have one artery feeding for it now, and also the anatomical variants right are a little bit different to each one of us. Maybe we're looking at another way that we are categorizing those arteries and trying to do the thrombolytics, and maybe some people are performing better than others. Because they are favored by the anatomy itself,
And not
Right.
just the abdomen, remember, you have an abdominal artery that comes out the carotid, but a significant portion, somewhere from 15 to 20%, also get laterals from the middle of the jaw of the ECA. So there is, there is redundancy working for the abdominal artery. We don't know as much about the central retina, or we don't see the central retina. We do this procedure, we just look at the retina flush.
Right, yeah.
But so small that
We can analyze it. That's a good point, the redundancies, and as, Dr. Hassan was saying, for each patient, like, let's say someone has a distal occlusion, and they have a carotid on that same side, or like, they have so many different areas that are occluded, even just getting to the clot is gonna be maybe difficult or not for us, and they're within 9 hours, they're, it's attitude where they're aphasic. So maybe these patients should be considered more, right? Especially they have redundant, with the carotid slowly closer, how they kind of built up a lot. The posterior and the ECA. I think everyone, it's so different, especially in our population, because their vascular tree is so unique to what they are. So like a person who's coming in with the stroke 4 hours ago, maybe the stroke happened like 15 hours ago.
Right. Yeah.
So it's like, it's really hard to have an absolute time. It's 4.5 hours. Their stroke happened earlier, their laterals are different. I mean, as Ravi explained to all the studies, we're still trying to figure out what that best imaging criteria is. And that's where I think you guys have a discussion with family to talk.
Yeah.
Based on our imaging characteristics, based on how his vessels look, based on the symptoms that he has, we actually think TPA is gonna really help with the morbidity and mortality for him as well. We can recommend it just based on these little trials, and again, it's not standard of care. If you guys are willing to accept that risk, that one, you may bleed, probably asymptomatic if you bleed, but if he bleeds, it could be devastating as well. So, but the option is if you don't, you really like not be able to talk. So those kind of things are important to discuss. And unfortunately, not everyone. It's hard to have that discussion when you guys are trying to do a million things.
Right, yeah, and we've seen there has been trials that looked at patients, and beyond the 4.5 hour, they would come in and they would have a small core, and then you would have patient who come in within 4.5 hour, but they have a large core. So it's very different and variable. But ultimately, you have to look at like the patient, and you have to look at the scans, and you have to make a decision like, with this patient going to benefit from thrombolytics or not. The risk of hemorrhage is, I think regardless, it's like 2-3%. But if you have tandem occlusion, like how Dr. Fakri is explaining, you really have to look like, hey, if we do this, is there going to be a higher chance of complications or benefit? Yeah. All right. Any more questions? Well, thank you so much. Thank you, Dr. Hassan. Thank you, everyone joining online.